Hi, good afternoon, everyone. So I'm Shamil Haroon. I'm a public health researcher and also a GP. Really pleased to be presenting at this meeting, and also wonderful to hear the last talks, giving me a lot of food for thought. And also, as a clinician, the idea of failure makes me very nervous and scared. So it's really nice to be able to talk about it in the open. So I'm going to talk about an experience that I had on a research study called the TLC study, or Therapies for Long COVID, and some of the lessons that I learned from some of the failures that I encountered in that study. So just before I start, I want to acknowledge all the people who were involved. It was quite a big team effort, including the research team, colleagues over at the Clinical Practice Research Data Link, Aparito Limited, our patient partners, the participating GP practices, and the funders NIHR and UKRI. So the problem that we were trying to address is all about trying to understand long COVID, or post-COVID-19 condition, as it's also known. It's a significant public health challenge, and there are estimated to be 40 million people worldwide who have experienced long COVID. And it's defined as the continuation or development of new symptoms 3 months after a SARS-CoV-2 infection, with these symptoms lasting for at least 2 months with no other explanation. And I'm sure all of us will have encountered people who've had long COVID and know what a debilitating condition it can be. It's highly heterogeneous. It has several different phenotypes, and most of the data that was there at the early part of the pandemic was largely based on hospitalized cohorts, and data on symptoms on non-hospitalized people, which was the majority of affected people, was really quite lacking. So that was what we set out to do. So we were given a large grant of £2.3 million from NIHR and UKRI to study long COVID in the wider community. It was quite a big project. There's a number of different work packages. There were 5 in total. I'm just going to focus on one aspect of the study in the interest of time, which was about establishing a cohort of people with long COVID and a matched control group, and describing the symptom burden and other health measures in that cohort of people that we were going to recruit from primary care. And you can find further details about the study at our protocol paper. So we aim to collect symptom and other patient-reported outcome data from non-hospitalized adults with a history of SARS-CoV-2 infection more than 12 weeks following that infection, and also a matched control group. And we involved general practices here. So we identified eligible practices and patients from a large primary care database, which I'm sure many of you have heard, known as CPRD Aurum. So this collects data from all around England, primarily from general practices that have signed up to CPRD, and they're all primary care health record data and linked hospital episode statistics data. We extracted that data using a data platform that was developed at the University of Birmingham, known as Dexter. We went to great lengths to sample these practices to be representative of the populations that we were particularly interested in them. So we used something called probability weighted sampling to ensure adequate geographic representation. We oversampled practices that had a larger number of patients with a history of COVID-19, those from a lower socioeconomic status, higher proportions from Black and ethnic minority groups, and balancing urban versus rural practice. And we went to great lengths to attempt to do this. Practices were then invited, those that we selected were invited to participate through the CPRD's interventional research studies team. And the practices were offered payments based on the study setup, the screening of patient lists on the interventional research studies platform, and practices were paid per patient that they invited to the study. We also, as a research team, held regular engagement meetings with practices to talk about the study, give practice opportunities to ask questions, and also to give updates on the research findings to help improve engagement. We also recruited patients who met specific eligibility criteria who were registered at those practices. So cases were age 18 years and older with a positive SARS-CoV-2 test result, either by PCR or lateral flow test, and had not been hospitalized within 28 days of their diagnosis. We also had a matched control group with similar profile but hadn't been diagnosed with SARS-CoV-2 or had no evidence of that. So each case was matched to 4 controls using a statistical method called propensity score matching based on their age, sex, ethnic group, and socioeconomic status, and a comprehensive list of comorbidities. And we aimed to recruit 4,000 cases and 1,000 controls. That's what we said in our grant application form. And patients were invited by post, by text message, by email, and we gave practices the flexibility to use the approach that best served their practice setup and their patient populations. So in total, we managed to recruit 72 practices, which we were all very pleased about, across England, and 43 practices, or 60% of those, recruited at least one patient. So the total number of patients that were available for GP review were 9,368, of which 57%, so just over half, were actually reviewed. A fifth were rejected because the GPs felt they were not suitable for recruitment. But ultimately, we only had 5% of those invited who onboarded onto the study platform and provided baseline demographic data. So based on the observed recruitment rate, we would actually have needed to have invited about 96,000 participants to achieve the desired sample size, which was 22 times the number that were invited. So why did this happen? So recruitment of practices and patients took place during the pandemic, during a time of unprecedented pressures on primary care services. Weren't clear how well practices were actually trained in research participation. And there was little on the ground support for practices such as research nurses, and we couldn't rely on the clinical research networks because of their funding models. We had extensive PPI, patient and public input into the recruitment methods, but was this sufficiently representative of the typical research participant? Could there also be research fatigue? You know, lots of people had been invited for studies around the COVID pandemic, and were patients just overwhelmed by being invited to too many studies? And also, was there a waning interest in the research topic? People wanted to move on from COVID, and perhaps there was a reducing interest over time. So how do we work around this? Well, we used existing routine data from the CPRD Aurum database to evaluate symptoms in a cohort of infected individuals of 48,149 patients, and a matched group of uninfected individuals of 1.9 million. And it was a huge team effort. We didn't actually think at the time we could use routine data to try and answer the question we had sought out to do, but we were able to do so. And the findings were published in Nature Medicine in this paper, Symptoms and Risk Factors for Long COVID in non-hospitalized adults. We made all the code lists publishable. We published all the code lists on GitHub so that it was reproducible. And we also replicated the study with a colleague based at UCL who used a different approach using natural language processing to validate our results using a different database. So what lessons did we learn? Well, prospective data collection in primary care is extremely challenging. Always have a backup plan. Assess whether the research question can be answered using routinely available data, and be explicit about the limitations and how you interpret that. Prospective data collection from primary care requires a strong physical presence at practices to support research activity. You need boots on the ground to make it work. You can't do it at arm's length, really. Assume low recruitment rates and adjust the sampling frame accordingly. Pilot recruitment processes, have a pilot phase in your study, and be flexible in the recruitment approach. And set feasibility criteria, know when it is appropriate to proceed with the full study. and don't keep going on with the wrong strategy if things are not going well and hope that it will somehow magically work out.